Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by three paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Hi guys, and thank you for tuning in. If you would like to create a list of the least favorite jobs, I bet that obs and gynae maternity would be very, very high on this list, with complications of delivery, of birth on the very, very top. So we decided to discuss it today. Without further ado, let's roll the intro. Harrison Steed, Timo Silver, Alex Hepner. Hi guys, how are you today?
Good, thank you.
Very good, Alex, thank you.
Cool. How's your maternity perception? Do you like those type of jobs or not really? Harrison?
It's not something we go to very often as paramedics, and I think as a result of that, we're not great at dealing with it. Some people I know in my service work as midwives as well, so those people are very good at dealing with maternal emergencies. But generally speaking, it's not something that's often sort of talked about in practice, I suppose, which is bad, because usually when we're going to these things, they're unplanned or complicated in some fashion, even if it's just the complication being the fact that it's out of hospital. So I think we all need to be a little bit more prepared than perhaps what we are, at least in my experience.
How often do you go to maternity jobs in Australia, mate?
Not very often. So, I mean, I've only been to, the last 2 years I've been to one. So they're not too common. But it all depends on where you work as well, and how far away the mother is from their the nearest obstetric hospital as well. Obviously that's going to factor into whether they're going to be in labour outside of hospital. So not very common. It's definitely one of the less frequent jobs.
But would you say that one a year, two a year, roughly?
Yeah, I'd say to average it out, you probably maybe get one or two a year, or one every 1 to 2 years. But that being said, I know people that have been to several in the last couple of months, so it's like all of our jobs, we can't really predict what we're going to.
Yeah, absolutely. Timo?
Yeah, I actually don't mind them at all. I kind of like them, but in Finland, I've only been to one, I think. Maybe two, but one delivery in the truck, and then one that wasn't delivered in the truck that we got to the ward in the hospital. But in the UK, when I was working there, I had 14 deliveries. So yeah, it's a bit different. But luckily, I had the best possible teacher when I joined the UK NHS ambulance service. He just happens to be sitting here with us on the stream today.
You are very kind. You are far too kind, mate. Thank you. Guys, I love maternity, to be honest. When I joined ambulance service, because I started my career as a paramedic on A&E, and then intensive care, and then pediatric intensive care. And when I left pediatric intensive care, I was like, I will really miss maternity jobs, because we were called to A&E, to wards as support, if you like, or backup in terms of maternities and maternity jobs and complications of delivery. But when I joined ambulance service, I found out that actually I attend more maternity jobs than as a member of the crash team on pediatric ICU. Anyway, this way or another, shoulder dystocia today. Complications of birth is a quite tricky subject. I have a problem with maternity jobs. How we teach maternity, because in majority, and please correct me if it's a bit different in your countries, guys, but in the UK and in Poland, we tend to push the maternity topics, the maternity subjects onto midwives. It's almost like it's like a mystical knowledge. They know what to do. We are not really happy with it. Is it the same thing in Australia and Finland, Timo?
Yeah, it is the same. it's quite clear that they only give like the bare minimum of knowledge in the Finnish paramedic school to deal with maternities, and then obviously people are going to be quite anxious about going to maternity jobs, and then we have systems in place for midwives to come out, so then that also exacerbates the issue of struggling to deal with the actual maternity as a paramedic. So yeah, there's definitely a lot that can be done in terms of education for paramedics for maternities. That's not being done right now.
Harrison?
Yeah, so as I mentioned before, there are some paramedics in my service that are dual trained and currently work both as paramedics and midwives, which is, I think, an interesting combination and a good combination. I know of some male midwives paramedics as well, which is, I suppose, a even less common combination. But I think it's similar over here as well. A lot of the maternal education obviously is focused towards the midwives, and we kind of receive the bare bones. But I suppose that sort of applies to a lot of the stuff as well. We kind of have to be jack of all trades, master of none kind of setup. We have to know a little bit about a lot of stuff, and it's a bit difficult for us to go into detail. But yeah, the education over this side of the whatever ocean separates us. I've got to check my map. Over this side of the ocean. Yeah, it's a little bit limited. Our scope of practice is very reliant on consultation and at the direction of an obstetrician or a midwife. There's fewer things that we can do autonomously compared to a midwife in the same scenario.
Are you, or can you be backed up by a midwife, or do you have like a hotline where you can call and ask and say, "Oh, mate, that's what I'm facing now. What should I do?" in Australia? So we have a service called PIPER, which stands for the Perinatal Infant Pediatric Emergency Retrieval. So it's a centralized service that deal with all sorts of issues around obstetrics, neonatal and pediatric emergencies. So they're primarily a consult service and a transport service as a sort of inter-facility transfer. Theoretically, they can respond out to a job. They usually operate outside of the Royal Children's Hospital here in Melbourne, the major metropolitan children's hospital. So theoretically, they can respond from there direct to a scene, but obviously in a job like shoulder dystocia, it's quite time critical. So to be able to have them on scene at a job like that would probably not be feasible in terms of time frame. But we can consult with them quite readily via phone or via the radio, and have expert consultation over the phone, which is very, very handy. What about the midwives? Can they attend? Like, can you call them as a backup and they can, I don't know, jump on the car and see you on the job?
Yeah, and so theoretically, yes. So it'll usually be at the direction of that PIPER service, and you may be close to a tertiary maternal centre, and theoretically they may be able to drive people directly out to the scene. It's not something that I've experienced, but it is something that can be arranged if it's required.
Okay, Finland, Timo.
So like in my area and in most areas actually, the field leader is stationed at the hospital itself. So usually areas like ours has the system in place where the maternity unit in the hospital actually has like a alert system we can activate, and they will send us a midwife, and we will take them into the field leader vehicle, and with that to the scene, and then they can obviously help us there, and then assist with the conveyance.
All right.
Later on.
Will the midwife attend on blues, or are they in the personal cars? On the personal cars?
So that they will be with the field leader. So if I'm working like I normally work like some night shifts, I'm working as the driver for the field leader. So then I'll be the one driving on blues, the midwife and the the field leader
okay.
will be on board. So yeah, they respond on blues, but not by themselves.
Yeah.
Dare I say,
Is the field leader someone like a team leader in the UK?
Yes, it's like, I would say it's between like a bronze and a silver command.
All right. Okay. Cool.
Yeah, kind of like that. Yeah.
Harrison, in Australia, the midwives use blues, or are they transferred in the civilian car?
So, because it's not a very sort of common thing, not something I've experienced, primarily they would be with the Piper response. So the Piper service have their own ambulance, actually have several of them, which are staffed by usually some transport officers that are sort of contracted out through my service, and they can respond out. So usually that response will include an obstetrician and a midwife in the actual paediatric ambulance. In terms of responding a midwife direct to the scene, if required, it can usually be arranged through what we refer to as an in-field team leader. So it sounds very similar to your setup, where they may drive to the hospital and collect them and drive them out to the scene. Theoretically as well, it's happened with other services where specialists have need to be driven out to the scene. Will often also involve police as well. So they may be the escort. So they may drive to the hospital and collect the specialist and drive them out to the scene. I suppose theoretically that could happen with a midwife in our service as well, if required.
Yeah, so you guys are lucky, because in the UK we may be backed up by a midwife. However, she will return on the civilian car, so she won't have blues. And that's my point with creating this topic today. We need to be on the top of our game, because as Timo mentioned before, complications of birth like shoulder dystocia, breech, or umbilical cord prolapse, they are time critical. Those cases are time critical. So sometimes we don't have, antepartum hemorrhage. You don't have really time to wait for backup sometimes. Okay, let's get down to the business. Shoulder dystocia. What do you know about this condition? Let's start with the definition. Timo, what would you say what shoulder dystocia is?
I have to say, actually, I realized that I know barely anything about it before we discussed this topic, and I actually decided to not actually learn about it beforehand and actually come here with a blank slate.
Okay, cool. Harrison, from something from Southern Hemisphere.
So my understanding of the shoulder dystocia, again, it's not something I'm too acutely familiar with, but the issue being that when the baby is being delivered, there's no progression. So there's often either no restitution of the head, or for whatever reason, the progression through the birth canal is stopped, and it's usually from the anterior shoulder being stuck behind the symphysis pubis of the mother as well, and it creates a lot of issues. So the forces involved can result in a brachial plexus injury to the infant because of the stretching of the nerves there as well. But there's also an issue with the umbilical cord being compressed against the pelvic rim as well, which is why this is such a time critical emergency. You know, we in our guideline we say 5 to 7 minutes after you've identified shoulder dystocia. You really need to get it done within that sort of 5 to 7 minute period.
That makes sense. So within the UK, we have a few different guidelines. You have your JRCAL guidelines, and you have, which I think that the best guidelines are from Royal College of Obstetricians and Gynecologists. And what the guidelines say is basically what you just said, is a lack of progression. However, the definition here is when the cephalic delivery requires obstetricians manouvers to deliver, and gentle traction has failed. And that's where I have a problem here, because as a paramedic within the UK, within my scope of practice, I should not be using any axial traction on the baby. And the definition is no progression, and the axial traction failed. That's the problem. In terms of incidence of the shoulder dystocia, it's not really common. So guys, whoever is listening to us or watching us, by the way, pop in and say hello on YouTube, Facebook, Twitch, or LinkedIn Live, guys. The incidence is quite low. According to latest data from Royal College of Obstetricians and Gynecologists, is between 0.58 to 0.70. So it's relatively low. Guys, in your countries, do you have any numbers from Finland or Australia?
I actually don't know our numbers for that. I would assume it's pretty much the same.
Harrison?
Yeah. One of the state guidelines here does mention it's usually around sort of 1 in 300, which works out to about the same percentage that you're mentioning there as well. So I think given our health services are reasonably on parity between our three countries, and the maternal education be about the same, it would probably be about the same across the board, I would imagine.
The problem with shoulder dystocia is, however, this condition is not very common, as we already agreed. It may lead to serious complications and morbidity either for mom and baby, even if this condition is managed properly. And that's the big message to our listeners and viewers today. If you will manage shoulder dystocia properly and something will go wrong and the outcome won't be as you want, please don't beat yourself up about it, because that's a recognized thing when you manage everything fine. You do everything by the book and still the outcome is not as you would like to. The most common complication from mother's point of view is postpartum hemorrhage. More than 11% of shoulder dystocia cases will end up with postpartum hemorrhage. For the baby, it's as Harrison mentioned, BPI, so brachial plexus injury. In this country, it's between 2 to 16%. However, again, very important message: 90% of BPIs will end up without any neurological dysfunction. So even if the baby will sustain BPI, most likely, fingers crossed, 90%, it will end up without any neurological dysfunction. I'm really happy that Harrison mentioned cord, because what I don't like about teaching shoulder dystocia is that people tend to say two things. A, that it is purely bony problem, is a mechanical problem, is a pelvis problem, and don't consider any other options, and tend to completely forget about umbilical cord. And as Harrison mentioned, the compression on the umbilical cord is quite crucial, because yes, people tend to say, baby is compromised because it's in the birth canal, is a very confined space, the chest cannot expand. And I'm like, no, chest won't expand. Remember, the whole fetal circulation is in place. The foramen ovale is open, ductus arteriosus, or ductus botali, if you like, is open. So it's not about chest not being able to expand. It's about compression on the umbilical cord and compromise of the circulation on this end. What about risk factors? Can you predict shoulder dystocia? Any thoughts from you guys?
So from what I read, there are some risk factors that are involved with shoulder dystocia, but the actual predictive value of them is quite poor. So there's often issues around like the gestational age being over 42 weeks, gestational diabetes, and particularly large birth fetuses like macrosomia, I believe is the appropriate term. That'll often increase the risk of shoulder dystocia, but at the same time, and I think the ARCOG mentioned that the over 50% or so of shoulder dystocia cases don't actually have any of those risk factors. So It's not the sort of thing that you can say, you have this, therefore we will have this, or there's no risk factors, therefore we won't have a shoulder dystocia. It's the predictive value is very poor.
Exactly. There was actually one proper research done in 2006 where researchers listed the risk factors for shoulder dystocia. Although you mentioned Harrison's macrosomia, so baby bigger than 4.5 kilos, diabetes, induction of labor, and previous shoulder dystocia. But as you said, more than 50% of those cases are just unpredictable. You cannot predict and you not prevent. Hence why we should know what to do. Now, lack of progression, and that's the next problem I have with shoulder dystocia. Quite often, when I was called as a backup on ICU or as a clinician, when I backed the crew up, they were like, "Oh, we're calling shoulder dystocia," And by the time I had a quick chat with mom, put her at ease, baby was delivered. So there is a time frame, and Harrison, you mentioned 5 to 8 minutes. It should be managed. Is that?
Yeah, so that's what's stated in our guidelines, and through the education that we had, it was particularly as mentioned around the issues with the compression of the cord. If it's sort of any extended time longer than that, then it's likely to be an unfavourable outcome. But even if it's within that time frame, you should really be preparing for a potential resuscitation scenario if you do have a delivery.
Okay, let's don't go into the fetal resuscitation or baby's resuscitation, because I will completely drift away because there's so many things we can say about it, and I hope that as we will discuss complications of birth, we will move towards newborn life support a bit later. However, lack of progression, and again, there was a research that mentioned that lack of progression from shoulders to head, more than 60 seconds, we can call shoulder dystocia. However, those data were not routinely collected, so we should not be using this time frame. Again, going back to the guidelines from Royal College of Obstetricians and Gynecologists, you think about axial traction, and that now, if guys, and I'm talking to our listeners and viewers, if your scope of practice, because we need to remember, Group Call Life is all across the world, from Australia to the UK, Finland, Poland, Germany. So I'm not just talking to British paramedics who cannot perform this axial traction. But if your guidelines allow you to perform gentle axial traction, gentle, and the gentle is the key word here, that's what you should do. That's the diagnostic gentle axial traction. So you put your hands on the baby's head, and if there is any visible part of the shoulder there, try to avoid any compression or on jugulars. And I know it's a very short neck, but still, if you will pop your fingers there, you can compress jugulars. So try to avoid any compression on jugular veins. And gentle axial traction, and axial traction, not the downwards traction, because back in 2008, 10, if I can remember, there was a thing about tractioning downwards. It's not the case anymore. It's just very gentle axial traction. And if there's no progression, you may eventually think about calling shoulder dystocia protocol. However, and that's a very important thing now, guys, there are many factors that can actually impair the progression of the baby through the birth canal. And I've learned it quite recently from amazing podcast called Biomechanics for Birth. If you guys can find them on Twitter, if you find them, or if you want to find them on internet, do it, because it's amazing midwife Molly, I'm saying hi to you. Thank you for teaching me this thingy. 3 main factors that can impair the progression of the baby are fear, medicines, and the biomechanical reasons. So let's start with fear. Why fear is so important? Why fear can stop the baby moving through the birth canal? Let's think about muscles. Psoas muscle, for example. Do you remember, guys? And now I'm talking to Harrison and Timu. Do you remember where psoas is? Harrison?
Nope.
I'm with Timu here as well.
Okay, so if you think about
anatomy is not
no worries. If you think about the spine, the lumbar area of spine, that's where psoas starts, and it goes through the pelvis to your femurs. And now this muscle is highly reactive to fight or flight triggers. Okay, so now if you think about psoas going from the spine through the pelvis to the femurs. It goes where the baby is. And if your patient will be scared, this fight or flight or freeze model will kick in. The muscle will get tensed, and when muscle gets tensed, it gets bigger, right? How do you think it will affect progression of the baby? Actually, it makes the whole pelvis outlet smaller. So we tend to say, especially, and I don't want to be I don't want to say racist, but in some countries, and I'm saying to my Polish colleagues, we are quite harsh with patients sometimes. We are like, oh, seriously, shall we be so pink and fluffy? Shall we light up the candles here and I don't know, put some music for our patients? Yes, that's what you should do, because fear is one of the most important factors that can impair this progression of the baby through the birth canal, and it's scientifically proven.
That's actually a really interesting point, and it comes back to pretty much the bread and butter of our work is reassuring our patients. Like, not just maternal emergencies, but everything you go to as a paramedic. I know there's more than just paramedics that are listening. How many patients have you improved just by reassuring them? How much analgesia have you given just by being kind to a patient and reassuring them and making them realize that everything's going to be okay? So it's actually really interesting that has a genuine physiological basis in the management of shoulder dystocia as well.
I will show you next one more thing and a trick that will actually make you even more surprised, but that's in a moment. I want to get back to what you said about TLC, tenderness, loving care. Support your patient, communicate with your patient, because you know what I observed, and please share your experience. But with maternity jobs, we are not really well trained, so we are scared. We are nervous, and we tend to react quite harshly, and our attitude affects patient's attitude.
Yeah.
We tend to, right, communicate with mother, communicate with next of kin. Don't let the woman to feel alone, to feel abandoned, to feel, I'm sorry, like a sack of potatoes. This is her best day in her life, and we clinicians, we can change this day into the worst day of her life. Let's not go there. Let's be kind. Let's reassure. Let's provide actual support. That's fear. So let's quickly recap. Progression of the baby can be impaired by fear. Okay. The second thing, medicines. Your patient may be on medicines that actually, I don't want to say stop, but will delay progression. So, and there's over 12 or 15 medicines that can do it, and that's different names in different countries, so I won't go there. Dear listeners or viewers, quickly research on the meds that are used in your countries that can delay baby's progression. And remember to check it with the next of kin or mother. And the last thing, the third element of this delay can be purely biomechanical. And now, I think that to me, as a pre-hospital clinician, that was the biggest game changer when I learned this thingy. What we tend to say to the lady who is giving birth, we tend to say, "Ma'am, would you mind spreading your legs?" Because we want to see the vulva, we want to see the birth canal opening, isn't it, guys? Is it the same in your countries? We ask ladies to spread her legs, and that's actually not really great idea. Now, what I want you to do, guys, is take your hands and sit on your hands. Come on, sit on your hands. Oh. Now, move your bum. Can you feel bony parts? Can you feel your ischial tuberosities? Yeah?
Yeah.
Okay.
Absolutely.
And I hope that you guys who are watching us now will do the same. Unless you're driving, then don't do it. So,
I'm glad all this is off camera.
okay, so now let's move our bumps. You can feel your ischial tuberosities, right? Now, slowly spread your legs and feel how ischial tuberosities are moving. Now, get your...
I'm wearing tight-fitting shorts, so it's not the most easy thing to do.
Are they moving outwards or inwards when you're spreading your legs?
Inwards.
Inwards.
So actually, spreading the legs, making the thing easy, worse. Okay, keep your legs spread. Keep your knees and feet apart. Now, what I want you to do is bring your knees together. Leave your feet where they are, but bring your knees together and feel how ischial tuberosities are moving. Where are they going now? Outwards.
Outwards, yeah.
Boom. Boom. For ages, we were asking ladies to spread their legs. And ischial tuberosities actually are going, and femurs are rotating inwards, making the whole thing even more complicated. So guys, my point is, I'm not saying that you will deal with shoulder dystocia like this, but I'm saying before you will panic, before you will call shoulder dystocia protocol, put your patient at ease. Check what about her meds. And 3, try to actually change her leg positioning. And that brings me to the very important point, guys. The best position for the lady who is giving birth is whatever she feels comfortable in. Okay? Don't try to force them to lay down or go in all fours or whatever position you are happy with. The first and most important thing is let the lady choose the position. Okay? Happy?
Yeah, I think the problem, like in a lot of cases, especially here in Finland, is that because paramedics are so scared of the actual delivery in the truck, we put the mom on the stretcher, probably legs facing the way we're going, so the wrong way around on the stretcher basically, and then step on the gas and then
treat them with diesel.
In that situation, and in that situation, if we have to then deliver on the truck, obviously the truck needs to stop and all that, but then they are already in the laying on their backs, and then the response is to obviously, oh, can you spread your legs, and then try to deliver from there. So I think maybe not move them that quickly, just see where it goes, properly assess.
Exactly.
Is it going to be a delivery on the field, or will we actually get to the hospital? And if I'm doubtful, maybe then actually deliver on the field instead of trying to get to the hospital in a big
And
rush.
that's important. That's a very important point, and thank you for making it, Tim, because you know what? The truck, the inside of the ambulance is our comfort zone. We know where the DVB is, we know where the suction unit is, we know where stuff is. We feel comfortable. What about your patient? The comfort zone...
Not so much.
Exactly. The comfort zone of your patient is in their houses, in their home. Now, because of COVID, we will attend more and more home deliveries, or home birth, if you want, because people don't want to go to hospitals. Hospitals are not friendly and clean places anymore. So keep that in mind, and remember, tenderness loving care, keep them in the comfort zone. And by all means, if you need to call for backup, call for backup. If you need some expertise, call midwives or obstetricians. If you have a hotline number, use the hotline number. Now, moving to the famous or infamous MacRoberts maneuver. Okay. So we tried all those tricks with shoulder dystocia. So we tried to put the patient at ease. We checked that they are not on any meds. We tried the leg positioning, and that's failed. If you can, gentle axial traction, that's failed. Okay, now you want to try MacRoberts maneuver. Harrison, do you use MacRoberts maneuver in the Southern Hemisphere?
Yes, yeah. So the McRoberts manouvre is our sort of first intervention, we'll say, once we've identified that we do have a shoulder dystocia, and we do in our protocols have an allowance for a gentle traction to try assist with the shoulder. Generally speaking, no, but if it's something that we're considering maybe an issue, then we can start with that. But McRoberts is our next stop. We'll say next.
How would you describe this maneuver, mate?
We always have it described as the knees to nipples. I'm not going to attempt to do that on camera because I want to maintain our subscriber base and not put anyone off. But also, I'm just not that flexible, so I don't think I'll be able to do it myself. But yeah, they're basically the flexion of their legs. Their knees to their chest. You want their thighs right up against their abdomen, and as Alex mentioned, and we've just demonstrated as well, you want their legs reasonably straight. You don't want them sort of flailing out into the sides there.
So, what, in your opinion, what's the most important part of the MacRoberts maneuver when you are putting the lady into the MacRoberts position? What is the point you are focusing on?
My understanding of it is the angle of the birth canal. You're trying to open up that angle to allow for a wider passage.
So in plain English, you want to bum up. Exactly. So
Yeah.
And that's one of next problems I'm dealing when I teach shoulder dystocia, or when I'm discussing shoulder dystocia, or when I'm backing clinicians up on deliveries, on birth complications. Lady is on her back with her knees by the chest, but her bum is flat on the bed or stretcher or floor. The whole idea of the MacRoberts is to move the bum up, okay, from the flat surface. Now, in terms of knees, my personal view is that knees should be close to the chest and as close together as you can. But again, if you want to spread the legs, try. The whole thing about MacRoberts is just trying to change positions. And what Harrison, you have the lady in MacRoberts position, and what's now for you guys?
So
what you are doing?
After we've attempted McRoberts position and sort of up to about 30 seconds or so, if we haven't had progression through the birth canal, we'll move to a suprapubic pressure.
Is it intermittent?
Yeah. So we'll often sort of apply between two different styles. So your hands in a similar position to CPR on the suprapubic area, and you're trying to displace the anterior shoulder of the infant, and you'll either be sort of pushing at a 45-degree angle, trying to sort of rock back and forth, or pushing with sort of solid firm pressure as well. So sometimes that alternation, as you said, it's all about trying different things. One thing, it's not going to work for every single application. So.
And let me just stop you there. I want to quickly discuss this motion, because in majority of textbooks and unfortunately internet videos and materials I know, they used to say CPR style. Do it in the CPR style. And what CPR style means for paramedics, straight down. It's not. You don't want to squeeze the baby.
Pushing away.
Exactly. Now, quick question to you guys. If you want to perform this maneuver, where should you stand? Should you stand facing the baby's face, or should you stand facing the baby's occiput? And why? Because it's easy
I would
to
say. Yeah, I would say the occiput.
Why? Yeah, that's a good.
So you're trying to push against the posterior side of the anterior shoulder, and you're trying to displace it downwards and sort of achieve the restitution of the head.
Exactly. Because you want to achieve this bum to thumb or bum to tummy position. So you want the baby's face to be directed towards mother's bum. Does it make sense? Bum to thumb. Does it make sense or not really?
Yeah, it does.
No, keep in mind that English is my second language. Okay, so I'm looking at confirmation
but
that
as the resident tabula rasa here, yes, it does make sense. Yeah, I think so.
cool. So again, you want actually to move the baby, or what's the best word, Harrison? Twist. Help me
Yeah,
here.
sort of
Like
push. Displace, we'll say. You're trying to move that shoulder from behind the symphysis pubis, and hopefully you'll achieve that with that sort of rocking motion or that firm pressure.
Exactly.
To try and, I guess for lack of a better term, pop that shoulder downwards, rotating it.
And you want to achieve bum to thumb. So
bum to thumb. Yeah.
Exactly. Cool. Now, what if this won't do any good? What if you're still not successful? What Royal College of Obstetricians and Gynecologists say is try to change the position into all fours. Maybe changing the position will help. And then if all fours won't help, again back into MacRoberts and so on. Now it's time for internal maneuvers, and that's where many paramedics are like, okay, that's it. I'm not crossing this line. And in this country, in the UK, we are not allowed to perform any internal maneuvers. That's when the midwife or obstetrician comes to play. Harrison, what about internal maneuvers down there in Australia?
Yeah, you're sort of a double meaning with that, isn't there? So it's similar here. So I know during my undergrad degree, we had an excellent midwife that was taking our unit, and she did walk us through all the internal maneuvers. To the letter of our guideline, it's not in our scope of practice. And I've looked up several other guidelines from New Zealand and some other states here in Australia, and pretty much across the board, paramedics aren't generally able to autonomously perform these internal maneuvers. However, it's something that may be performed under consultation. So as I mentioned, we will consult with that Piper service or whatever service applies to that particular paramedic at the time. We'll consult with an obstetrician or a midwife, and it may be generally done under their direction as well. So although it's not specifically, we can't sort of autonomously go and, put our hands internal and try and manipulate the infant. It is something that we may be able to do on direction. But that being said, it's something that my university did show us how to do. It may not be standard curricula. It may not be across the board. So it may be dependent on the individual paramedic as well and their comfort level with that procedure.
Okay, so what would you do? How you insert the hand? Do you use this Pringle fingers?
Yeah, that's how we were shown. I've got reasonably large hands, so I may not be the perfect person to do this. But yeah, the sort of, imagine you're trying to get the last Pringle out of the jar, which I can never do, so I just turn it upside down anyway. But you're trying to sort of get your whole hand, thumb and fingers inside the vagina, and trying to manipulate the fetus. And there's a couple of different procedures.
Okay.
You're either trying to move the posterior arm. So if they're in McRoberts position, the arm that's facing downwards. If their arm is sort of across their body like so, you're trying to draw their arm up and out, and you've delivered one arm, and that sort of essentially reduces the diameter of the baby trying to being birthed. So hopefully displace that anterior shoulder. And if you're unable to do that, then doing the sort of the wood screw maneuver. So you're sort of pushing on the anterior portion of the posterior shoulder, pushing that while another provider is doing the pressure on the symphysis pubis externally to try to rotate from both shoulders there.
Yeah, that's basically what we would do here. Of course, if the scope of practice would let us do it. Okay, time for a quick recap.
I'm a specialist paramedic currently overseas in the Falkland Islands. and you're watching Critical Live.
So, shoulder dystocia. This is a time-critical condition because of compression or possible compression on the umbilical cord. But before you will call shoulder dystocia protocol, make sure that you did everything you could for your patient to A, put them at ease, be kind, be gentle, communicate with your patient, don't force them to do anything, and most importantly, don't put your fears and your stress on the patient's shoulder. This is the best moment of her life. Don't make it the worst moment of her life. When you want to call shoulder dystocia and your local protocols allows you to do so, perform gentle axial traction. You don't want downwards traction. That's a big no-no. It's a gentle axial traction. Try to avoid any compression on jugular veins. If the baby won't progress, try changing positions. Encourage mom to put the knees together, feet wide apart. If it won't work, go into MacRoberts maneuver, making sure, or MacRoberts position, making sure that the bum is up. It's not about just raising the legs. It's actually about moving the bum up. Then try to actually perform intermittent pressure on the shoulder, but you don't want to squeeze the baby. There's nothing about CPR here. It's moving the baby or trying to twist or rotate the baby, and you want to be behind the baby's occiput because you want to achieve this bum to thumb position. If that won't help, ask mom, encourage mom to move her position into all fours. Then if all fours won't help, go back into the MacRoberts. And then if you can, only if your local protocols allows you to do so, bring your fingers and internally you want to try to either grab and move the shoulder, or together with your colleague who will actually perform the external pressure, you want to twist the baby. And again, bum to thumb. Guys, the shoulder dystocia is not only a pelvic problem, a bony problem. There's more to the game. I always say that if you try to teach shoulder dystocia saying only about bones, it's like teaching midshaft femur fracture without mentioning the muscles. It's like musculoskeletal injuries. It's musculoskeletal. It's not only skeletal problems. Same with pelvis. There are more things to the game. Remember about psoas. Remember about the rotation of the femurs. Before we will finish, let's quickly jump across the ocean to see how American colleagues deal with shoulder dystocia. Hi, Gina.
This is Gina LaRue-Wendy with the United States of America. Today we're talking about shoulder dystocia. I'm not sure about anywhere else in the world, but we in the United States call it the turtle sign. Makes sense. The head comes out with contraction, the head goes back in. The head comes out with contraction, the head goes back in. Kind of reminds you of a turtle, right? Turtle, turtle. So with that being said, please follow your local rules, your local protocols with every state, region, medical direction. Do whatever your rules and regulations say to do. Here, they promote the first step is McRoberts maneuver. So McRoberts maneuver is pretty classic. You lay them flat on their back and or whatever position or wherever you found them. Lift their hips up with some padding. Put the extreme knee to chest position. So if you're visualizing this, I would think of like a gymnastics tuck, knees to that chest. And then take your hand and place that on the pubic symphysis bone. What this does is create that opening for that, like a bigger opening for those shoulders to come through, which is why that baby is stuck. It could be for many different reasons. Maybe a gestational week period, maybe they're 41, 42 weeks, maybe it's diabetic, or you just could have a big baby. So for whatever reason, we need to get this child out. There's also different rules and regulations with your protocols. Please follow them. You could try a gasket maneuver. A gasket maneuver is where you lay on all fours, kind of like doggy style or child's pose, those that are in yoga. So with that being said, then you take your hands and you push on the infant's shoulder inferiorly, which may allow it to slide underneath that pubic symphysis bone, kind of creating like and then back out. Depending upon your licensure and your rules, you might be able to do a wood screw or Reuben maneuver. This means you insert a gloved hand into the vagina where you kind of locate the humerus bone and then gently rotate the infant's arm towards its sternum and then inferiorly displace the shoulder away from the vaginal wall and attempt to shorten the diameter of the infant's skeleton. So this means that we're actually moving an appendage inside mom so that we can make it kind of fit through that vaginal canal. Now, with that being said, in extreme circumstances, again, physician most likely be able to perform these maneuvers is like they literally take the kid and shove it back up into mom. They place this baby back into that womb so that they can do an emergency C-section, which makes sense. And then with extreme circumstances, what if they can't do that? Then that's when the dislocation and other complications would occur. But whatever it is, please call your medical control if you need any more information, more guidelines, more guidance of what the heck to do in this situation. Childbirth is an amazing thing. I've delivered several kids. But when there's always a complications, you have that oh crap factor. So number one rule is to breathe and then take care of mom and baby. And I hope you guys have a great day and good luck and take care. Bye.
Breathe. That's a good advice. Harrison.
Yeah, so I kind of want to echo Gina's point there. A, breathe, and B, seek help. Get your medical control, your outside consultation services organised. And speaking of, there's one sort of final point that I wanted to bring up. It might be a bit of a controversial one and not practiced in many services, if any, but that's of pre-hospital episiotomy. So I was reading through a couple of my guidelines and I could only find one service that I was aware of that even mentions it, and it's definitely not part of a general paramedic scope of practice. But one of the services in New Zealand does make mention of a consideration for an episiotomy on the direction of an obstetrician or a midwife. When reading the guideline from the Royal College of Obstetricians and Gynecologists, they mention that the episiotomy doesn't actually help in terms of fetal or maternal mortality or morbidity, but the benefit in performing it in shoulder dystocia is that it helps to assist with actually performing the internal maneuvers. So if you've got reasonably large mitts like myself and can't actually get access and that's your only other option, it may be something to consider. Now, at ALS level here, we don't carry any surgical instruments. The cricothyroidomy kits in the intensive care paramedic kit do have a scalpel in it, so that would really be the only case in which I can foresee that happening in my service. You're not really trauma shears, they can't even cut a tea towel, so they're not going to be cutting through human tissue that well. But it may be something else if everything else is not working, that you may have to consult and consider doing. So it definitely wouldn't be my first port of call. It would be my last resort. But another thing to bring up. But I just want to reinforce the most important point being that get help. This is not something in hospital. They seek help and they've got 20 people around them. If you're working as a 2-up paramedic crew, you're going to need help. You may have some family there, maybe the father or or another parent there. but you're going to need some extra hands. So make sure you get that consultation.
Absolutely. If you have to do it, I'm not a big fan of this procedure, and the reason being is that I deeply believe that if you will put your patient at ease, all the muscles will actually relax, and the tissue will be more stretchable, if you like. So I think I've assisted in 3 maybe in hospital procedures like this. I never liked it, and I think that there are different options, and you can use your different skills and maneuvers to actually avoid that. But if you have to do it, by all means, you do it. Just please.
You didn't like it, and I dare say the mother didn't
absolutely.
like it
and you know, guys, just please do not try to what's the word I'm looking for? Use any tools apart from designated tools, and only if your local protocols allows you to do so, and you are actually trained to do so. Any more questions, guys? Anything from you? Any questions from our viewers? Gina was with us for a second, but she got a job, so she had to jump out. But she was on the chat. Ladies and gents, thank you so much for tuning in. I hope you enjoyed this episode. If you have any questions or comments, please do not hesitate to pop them in the comment option below. That was Harrison Steed, Timo Silver, Alex Hepner. That was Group Call Live, and hopefully see you in 2 weeks.